everyone. We're back with another lecture, and today we're going to speak about the microsurgical anatomy of the Cerebellopontine angle. The presentation is prepared from Dr. Albert Rhoton's Microsurgical Anatomy book. This is one of the best, if not the best, microsurgical anatomy book I've ever seen. Dr. Rhoton was a very down-to-earth neurosurgeon. I've met him on several occasions. Very knowledgeable, very down-to-earth, very friendly, and his book is, I think, is the main book that every neurosurgeon should thoroughly read. It's a very dear book to my heart because before my my PhD/MD exam, I started studying from it, and for about 3 years I kept summarizing chapters and presenting lectures from it, and I found it extremely useful for everyone. So today we will have to familiarize ourselves with some terms related to the Cerebellopontine angle. These terms, once you familiarize yourself with them, you'll be more comfortable, more oriented when you operate on the Cerebellopontine angle, and to understand the different pathologies, their locations, and the best way to address them all the time. I will keep mentioning some of the tricks and some of the pieces of advice and pieces of wisdom that I learned from my mentors, because they are very important. In neurosurgery, our main target is always to hit the main pathology. That's why the disease that we don't know a lot about are the difficult ones to treat. The ones that we know about are easier to tackle and treat. So that's an important thing. Some terms related to the Cerebellopontine angle. To start with, we have the Cerebellopontine fissure. What is the Cerebellopontine fissure? What is its relation to the Cerebellopontine angle? Where is the Cerebellopontine angle located? What is the relation of the Cerebellopontine angle to the cerebellum? Do we have any choroid plexus in the Cerebellopontine angle, and why is it important to know if we do or we don't have choroid plexus in the Cerebellopontine angle? What's the petrosal vein, and what is the surgical importance of the petrosal vein when we discuss the Cerebellopontine angle? And what is the crista falciformis, or the transverse crest, and the Bill's bar, or the vertical crest, and why are they important to know about? As you can see, there are lots of surgical implications to the Cerebellopontine angle. In addition, there are three neurovascular complexes that are present in the Cerebellopontine angle, and each can be addressed in a different way surgically. So to start with, we always start with the bony anatomy or bony relations of the posterior fossa in general in order to speak about the Cerebellopontine angle. So the bony relations, you can see here, this anterior part is formed by the sphenoid bone and the occipital bone, and these both form the clivus. Laterally, you have the internal acoustic meatus in the petrous temporal bone, and you have the petrous temporal bone on the other side. So in the midline in the front, you have the sphenoid bone and the occipital bone. Laterally, you have the petrous temporal bone, and posteriorly, you have the occipital bone. Right? So this is the bony relation. In the posterior fossa in general, the rule of three is the main. So everything is a three. You have three bony surfaces. You have three cerebellar surfaces. You have three main fissures. The blood supply, the main arteries are three. Mainly, you have three neurovascular complexes. So it's very important always to remember the three. Three divisions of the superior part of the vermis, three divisions of the suboccipital part of the vermis. So always number three we will keep mentioning threes all the time. Now for the surface of the cerebellum, again, no surprise, there are three surfaces of the cerebellum: the tentorial surface facing above, facing the tent, and it's angled like a tent. The suboccipital surface, which faces the occipital bone, and then the petrosal surface that faces here, it faces the petrous temporal bone on each side. On the right side here, I have put the initials for the parts of the vermis in relation to the different parts of the cerebellum or the cerebellar surfaces. So the culmen, declive, and folium are in relation to the tentorial surface, and the tuber, pyramid, and the uvula are in relation to the suboccipital surface of the cerebellum. It's important, we'll talk about them later again when we talk about the anatomy of the posterior fossa and the surgical approaches to the posterior fossa. Now, this is a very important picture. This is our main for today. This is a picture, of course, from Dr. Rhoton's book, but I've made some drawings in order to highlight things more. You will see here lots of cranial nerves, so cranial nerve 5, cranial nerve 6, 9, 10, 11. And this is what we were talking about earlier in the second slide, which is the choroid fissure. As you can see here, this is the superior limb of the choroid fissure, inferior limb of the choroid fissure, and this oval part here is the Cerebellopontine angle. So the base of the choroid fissure, which is medial, as you can see, this is the midline, this is lateral, this is medial, this is pons, this is medulla, and this is the pyramid, olive here. So as you can see, the base of the Cerebellopontine fissure is the Cerebellopontine angle. This is one. As the fissure tapers laterally, it forms the narrow apex. So this is the apex of the Cerebellopontine fissure. So where is the Cerebellopontine angle? The Cerebellopontine angle is the base of the Cerebellopontine fissure, where the cerebellum curves around the middle cerebral peduncle and the pons. So this is the Cerebellopontine angle, right? Now again, some important facts, same picture again. So these important facts are, number one, you have all cranial nerves from 4 down to 11. So from the trochlear nerve all the way down to the accessory nerve, they all lie near or within the Cerebellopontine angle. Okay, let's prove it. So this is 5, 4 is a little bit higher up. So cranial nerve 5, trigeminal nerve. Cranial nerve 6, the abducens nerve, is the presence at the base of the Cerebellopontine angle or the Cerebellopontine fissure. Cranial nerve 9, 10, 11, so glossopharyngeal nerve, vagus nerve, and the accessory nerve. And here we have the facial nerve and the vestibulocochlear nerve. Right, so this is one. The second thing is we have cranial nerve 4 and 5 are in relation to the superior limb of the Cerebellopontine fissure, while cranial nerves 9, 10, and 11 are in relation to the inferior limb of the Cerebellopontine fissure. Now you can see here, this is the flocculus, right here, and this is the choroid plexus. So to answer our question that we've asked in the second slide, yes, we do have a choroid plexus sticking into the Cerebellopontine angle. How did the choroid plexus come here? Choroid plexus is usually found in the ventricles. So this choroid plexus is part from the choroid plexus of the fourth ventricle that is behind this part here, like back behind the pons and the medulla here, and it goes through the foramen of Luschka, which is the lateral foramina of the fourth ventricle, and it sticks into the Cerebellopontine angle because the CSF from the fourth ventricle goes through the median foramen of Magendie, it's a midline foramen of Magendie, and through the lateral foramina of Luschka, and that is how it egresses through the fourth ventricle. So yes, we do have choroid plexus in the Cerebellopontine angle. Now, cranial nerve 6, like we've said earlier, is near the base of the Cerebellopontine angle or the Cerebellopontine fissure. Right, again, this is a bigger one showing both Cerebellopontine angles here, right? Superior limb again, inferior limb again of the fissure, flocculus, and this is again part of the choroid plexus sticking into the Cerebellopontine angle. Right, so this is the bigger picture of the Cerebellopontine angle. some important things to show. Again, this is a follicular sticking into the Cerebellopontine angle. This is the 7th and 8th nerves. This is the 8th nerve, right? And then you have 9th, 10 and 11 right here, and this is the subarcuate artery. Again, subarcuate artery is an important artery arising from the anterior inferior cerebellar artery, which is the ICA. And why is it important? Because it supplies the blood, it gives blood supply to the dura of the internal acoustic meatus. And the importance of this is that in meningiomas, as you know, meningiomas get their blood supply from the dura, and this is important to know. We will have a complete lecture on the blood supply of the dura and its importance in meningiomas, because certain parts of the skull-based dura can be sites of anastomosis between internal and external circulation, and we will talk about their importance later. So the subarcuate artery gives blood supply to the dura of the internal acoustic meatus. This is cranial nerve 5 here, and then as it emerges from the pons. Now, you know that we all know that the nerves go in a certain orientation or certain arrangement inside the internal acoustic meatus. We have 4 nerves that we have to talk about when we mention that. We have the superior vestibular nerve and the inferior vestibular nerve here, and because they are hiding the 2 other nerves that are in front of them. So this is again on the left side, because you can see this is lateral, this is medial. The bone of the internal acoustic meatus has been drilled out, and you can see the dura of the internal acoustic meatus. This is posterior, so you can see superior vestibular nerve, and beneath it, underneath it, or caudal to it, is the inferior vestibular nerve. Lower down you can see the hypoglossal and the vagus nerves. Now, if you pull the superior vestibular nerve above and you pull the inferior vestibular nerve below, then you'll be able to see the nerves in front of them. So the 7th nerve and the nervus intermedius are in front of the superior vestibular nerve, while the cochlear nerve here is in front of the inferior vestibular nerve. So the arrangement of superior vestibular nerve, and in front of it, anterior to it, is the facial nerve and the nervus intermedius, and the inferior vestibular nerve, and in front of it or anterior to it is the cochlear nerve, and this is labyrinthine artery going to supply the labyrinth of the ear. Now, we've mentioned in the second slide again the crista falciformis and the Bell's bar, and we wanted to know why are they important. They are important because they divide the internal acoustic meatus. So this big blue circle here is the internal acoustic meatus, and it's divided by the vertical crest. So Bell's bar is the vertical crest, and the transverse crest is the falciform crest, or the crista falciformis. This is anterior and this is posterior, and like you know, it's the 7 up, so the facial nerve is up and the cochlear nerve is below. Behind the facial nerve, so posterior to the facial nerve, is the superior vestibular nerve, and behind the cochlear nerve is the inferior vestibular nerve. Now, this is a picture again from a cadaver. This is how you do a retrosigmoid approach. These are the mastoid air cells have been exposed as they are drilled out. This is how you wax them, put a fat graft. That's a different story. We'll talk about this in depth when we discuss the retrosigmoid approach, how to properly do it, how to minimize it, how to do a retractorless brain surgery on the cerebellopontine angle using only intermittent dynamic retraction when we talk about the approach to the cerebellopontine angle. Here you can see, again, as you can see, this is right side, this is anterior, this is posterior. You can see this is vertical crest, which is the Bell's bar. This is the transverse crest, or crista falciformis. In the compartment above and anteriorly is the facial canal, where the facial nerve is with the nervus intermedius, and behind it in the upper posterior compartment is the superior vestibular area for the superior vestibular nerve. Lower down below the transverse crest in the anterior inferior compartment is the cochlear area for the cochlear nerve, and in the inferior posterior compartment is the inferior vestibular area for the inferior vestibular nerve. So that's why I said this is the right side, because this is anterior and this is posterior. Right. So we leave the anatomy for a bit, and then we will get your attention by some of the differential diagnosis of the lesions in the cerebellopontine angle. You have to try to anticipate what you will find. You have to try to diagnose from the radiology and the presentation before you operate on the patient. This way, you will be able to try to anticipate trouble, try to avoid problems, and try to operate in this critical location with the least morbidity, because you know your anatomy well, and you kind of can guess what kind of pathology it is. Now, these are the different lesions. One of my professors, when I was still a resident in Egypt, and he used to tell me, when you get stuck and people ask you about the differential diagnosis, go systematic and then rearrange them according to which is more common in this area. So we go to congenital, inflammatory, infectious, neoplastic, and vascular. These are the main categories underneath. You can fill many of the differential diagnosis. In the Cerebellopontine angle, always when you put differential diagnosis, don't forget that there are certain things that can be normal. Certain structures can be normal. So we call them pseudo lesions. So pseudo lesions in the Cerebellopontine angle are asymmetrical cerebellar folliculus. We've seen the folliculus sticking into the Cerebellopontine angle. If they're asymmetrical, they can be confusing for a tumor. The second one is the choroid plexus, and that's why I mentioned what is the importance of having choroid plexus in the Cerebellopontine angle. Choroid plexus enhances with contrast, so it can mimic a tumor while it is just the choroid plexus of the fourth ventricle going through the foramen of Luschka into the Cerebellopontine angle. Again, congenital lesions, epidermoid and arachnoid cysts, they can be confusing, but the anatomy of them and how it look can differentiate between them. Lipomas can happen. Neurofibromatosis type 2, which is characterized by bilateral vestibular schwannomas in both Cerebellopontine angles. Anyone with bilateral vestibular schwannomas, he has neurofibromatosis type 2. That's spot diagnosis. Infections like meningitis, sarcoidosis, Bell's palsy, where the facial nerve can enhance up to a year after the resolution of the Bell's palsy, and Ramsay-Hunt syndrome with the vesicles in the external ear. How to differentiate between the Bell's palsy and Ramsay-Hunt syndrome by the presence of the vesicles in the external auditory canal. Sarcoidosis is mentioned in the inflammatory as well, because nobody is certain how it happens. There are lots of different theories. Vascular, you can have aneurysms of the vertebral artery, you can have aneurysms of the basilar artery, pica aneurysms. Sometimes the aneurysm can be confusing with a tumor if it's a large giant aneurysm that is thrombosed or partially thrombosed. So if it's too rounded, too circular, it's not sticking to a base, it doesn't seem that's arising from the brain or the cerebellum, then suspect it can be an aneurysm or a thrombosed or partially thrombosed aneurysm. AVMs again, and you can see lots of signal voids in the AVMs. They are not so easy to mistake. Of course, benign tumors, our top of the list would be the vestibular schwannomas. Second would be a meningioma, in addition to other nerve schwannomas or neuromas, like facial nerve schwannomas, trigeminal schwannomas. You can have choroid plexus papilloma, because there is a choroid plexus in the Cerebellopontine angle. And in addition to the glomus jugular tumor, one of the very vascular, challenging tumors to take out. Of course, malignancy. Never forget malignancy when it comes to posterior fossa. If you find a lesion in the posterior fossa, especially if it's intraaxial or it looks exophytic, then always think of metastasis. Brainstem gliomas can be exophytic and can stick into the Cerebellopontine angle. We'll talk about brainstem gliomas. There are different types of brainstem gliomas. We'll talk about them in one of our lectures. Ependymomas can arise and go through, again, the foramen of Luschka into the Cerebellopontine angle, in addition to a melanotic schwannoma, one of the types of the schwannoma that can happen in the Cerebellopontine angle. So these are all the diagnoses. The most common ones are the vestibular schwannomas. We see lots of meningiomas. We can see epidermoids and arachnoid cysts in the posterior fossa. Now, if you've heard before vestibular schwannomas, they tell you that look at the internal acoustic meatus, internal acoustic canal, is it widened or not? So why do vestibular schwannomas cause widening of the internal acoustic canal or internal auditory canal or meatus? The reason why is the Obersteiner-Redlich zone. What's this? What Obersteiner-Redlich zone is basically the area where the central myelin is transformed into peripheral myelin. And this area is about 11 to 12 millimeters from the brainstem. And it is inside the internal acoustic canal or internal auditory canal. So when you have widening of the canal, so this means that the tumor started in the internal auditory canal and found its way into the cerebellopontine angle. So that's why there is widening. If you look at a CT scan, for example, of a patient with a large tumor in the cerebellopontine angle, sorry, this is an MRI, not a CT scan, I'm just saying. So if you look at a CT scan of a patient with a widened internal acoustic canal or internal auditory canal, then you suspect this is a vestibular schwannoma, because meningiomas are not going to cause widening of the internal acoustic meatus. Now, I don't want this to be a very long lecture. I don't want you guys to get bored. We will continue this, but for the time being, I'm going to give you a small quiz and show you some images of the lesions in the cerebellopontine angle. So this is a CT scan of the head, and it's showing this hypodense area in the posterior fossa. So what's the differential diagnosis in this case? This can be an arachnoid cyst or it can be an epidermoid. So we don't know. So in this case, you need to do more scans or further investigation, and the scan of choice that can differentiate for you between a an epidermoid and an arachnoid cyst is the diffusion weighted images and the ADC, which is the, of course, you know that the DWI and the ADC, the diffusion weighted images and the apparent diffusion coefficient, are used to differentiate strokes to the acute strokes, demyelination, certain tumors, and the main one is the arachnoid cyst and the epidermoid. I'm going to give you a nice scheme on how to read the DWI and ADC later on, and just a simple slide, just one picture on how to read them systematically. Look at the DWI if it's dark or bright, and then you look at the ADC if it's dark or bright, how to exclude the T2 shine through, and then you will end up with diagnosing whether this is acute or an old event. So again, so this can be an arachnoid cyst, this can be an epidermoid. Arachnoid cysts are more globular, while the epidermoid find its way between the volume and it can push its way through the brain spaces. Again, this lesion is a bit characteristic. So you can see the base is at the petrous bone. It's not going into the internal acoustic meatus. This is the internal acoustic meatus. And if you can look here and look here, you will see there is some hyperostosis of the bone. So my first differential to think about is a meningioma, because meningiomas cause hyperostosis, and you can have 3 different types of hyperostosis. That's a different story when it comes to meningiomas. We'll talk about them later on. When we talk about meningiomas. You can see here again there is lots of venous drainage, because this is the right sigmoid sinus, left sigmoid sinus, or it can be a normal variant where this one is the more dominant. But this looks like it can be a meningioma where it's based on the petrous bone hyperostosis and there is no widening of the internal acoustic meatus. This third lesion is very interesting. You can see it's an MRI of the brain with contrast. So, and this is the posterior fossa, and this is the middle fossa at the same time, petrous bone, but you cannot see the rest of it here. And you can see this large tumor cystic areas, and it's going from the posterior fossa into the cavernous sinus, posterior cavernous sinus, and the middle fossa. And this is a trigeminal schwannoma, where it goes, the trigeminal nerve goes obliquely from the brainstem, from the pons, all the way up to the Meckel's cave, where it goes into the cavernous sinus. After that divides and goes into the Gasserian gangle is at the Meckel's cave, and then it goes into the middle fossa. So again, this is how the tumor spreads from the posterior fossa and all the way into the posterior cavernous sinus and the middle fossa. I will show you one of the patients I operated on who had a recurrent trigeminal schwannoma. And for these lesions, if you do a retrosigmoid approach only, you will not be able to take it out because the other part is sticking into the middle fossa. So you have to do a combined approach, a subtemporal and retrosig, or a retrosigmoid or a subtemporal and presigmoid approach in order to be able to take it out. Thank you so much for listening to this presentation today. I will see you in part 2. We'll talk more about the anatomy of the posterior fossa and of course lots of surgery on how to operate the retrosigmoid approach and how to address problems in the posterior fossa, mostly the vestibular schwannomas or tumors, in addition to the microvascular decompression of the cranial nerves, like in cases of trigeminal neuralgias and hemifacial spasm. Hope I didn't get you bored, guys. If you have any questions, please don't forget to ask in the comments section. All the best for you until we see you again.